So good morning, everyone. I'm Michelle. I'm one of the POCUS fellows. And today for our POCUS rounds, our topic is going to be POCUS applications in bones and tendons. I have no conflict of interest to disclose. And our POCUS rounds are now Royal College Section 1 activity. So you can get your credits by signing in using this link. Today's presentation is going to be divided into three main topics. First is skull fractures, then long bone fractures, and tendon ruptures. And the objective will be to understand how to perform these applications, interpret the images, and recognize the advantages and limitations within these areas. So let's start with skull fractures. So presume you're working a busy shift and you're seeing an 11-month-old girl who comes in with swelling of the scalp after rolling off the bed onto hardwood floor. She didn't lose consciousness, no vomiting, but on exam she has this huge boggy hematoma. So before you grab your ultrasound machine, you have to decide what is your clinical question. Are you looking for a skull fracture, or are you looking for an intracranial bleed? Because POCUS may be more equipped to answer the former question better than the latter. The transducer of choice would be your high-frequency linear transducer, because you're looking at pretty superficial structures. And in terms of the technique, you want to position the transducer over that area of swelling and scan the whole entire area, extending beyond the border of the hematoma for 1 to 2 centimeters. And you want to scan in 2 perpendicular planes. Remember to use lots of gel and to minimize pressure. And a key to success in little ones is to make sure you have a strong hold so that the babies are not squirming around and then you lose track of where you are. And so when they're tiny, you can swaddle them. And then when they're a little bit bigger, you can burrito wrap them. And it's also important to become familiar with the skull anatomy, specifically the locations of the cranial sutures, so that you don't mistake them for fractures. And to distinguish between the two, you can trace the sutures back towards the fontanelle. So your sagittal, coronal, and metopic sutures can be traced back to the anterior fontanelle, whereas the lambdoids in the back can be traced back to the posterior fontanelle in the babies where they're still open. However, the squamous suture, the horizontal little guy over here, may be difficult to follow to an open fontanelle, but then in that case, you can scan the contralateral side of the skull for comparison. And when you acquire an image, it would probably look something like this. So you have the intact skull here appearing as a bright, hyperechoic, curvilinear structure with some shadowing beyond it. And at the top, oh, does the pointer not work, David? Oh, okay, don't worry about it. And so this would be normal bony contour. And then here's another scenario. What do you guys see in this one?
Fluid. I have more structure.
Yeah, exactly. So it's probably, exactly. So if it's in the skull and it's boggy, it's probably an isolated hematoma. And in this case, it doesn't involve in this case, it doesn't look like it's involving the skull compared to a scenario like this. So how would you guys describe the findings here? Yes, cortical disruption, good. And you also see the depression of the skull as well, where there's a step-off deformity. Sometimes it's not as obvious, but it's still appreciable, where you see the cortical disruption. And then when we talk about following the suture, because you're not sure when you see cortical disruption, whether it's a fracture or a suture, you can follow the suture, as in this video, into the fontanelle. So where the fontanelle opens up and you see brain tissue, then you're more reassured. In terms of the evidence for a skull fracture, so this is probably the most quoted paper. This is a prospective observational study. It involved 17 clinicians undergoing brief training of an hour, and they recruited 69 patients, less than 21 years old, with suspected skull fractures, 8 of which had proven fractures. And they compared POCUS with CT findings and found that it had really good specificity of 97%, and sensitivity was also 88%. The only false negative was a skull fracture that was adjacent to the skull hematoma rather than directly below it. So this further strengthened the recommendation to scan beyond the border of the hematoma, because sometimes it can be not right underneath it. And when the data from that study was pooled with 3 other ones, this yielded a total of 185 patients. And in this pooled data set, the fracture rate was 27%, and they found a sensitivity of still very high of 94% and specificity of 96%. And so the pearls for skull fracture scanning is that when you can distinguish fracture from suture by following to the open fontanelle. You can compare it to the contralateral side. Remember to scan beyond 1 to 2 centimeters of the hematoma and to minimize probe pressure by applying lots of gel. However, there are some pitfalls that we should be mindful of. So when you have intracranial injury, it can happen in the absence of skull fracture. So just because you have a normal scan doesn't necessarily mean that there's no intracranial injury. Also, when you see a fracture, the degree of hemorrhage beyond it is hard to tell on POCUS. And so you still need to use your clinical correlation to determine whether this child needs a CT. Before we move away from skull fractures, let's entertain some potential applications that might be up and coming and perhaps controversial. So we mentioned earlier that POCUS can't really tell us what's underneath the fracture, but if the anterior fontanelle is still patent, could there be a way to look through it and identify any potential major intracranial hemorrhages? So this is the paper that tried to explore this idea. So they looked at 12 patients, 4 with confirmed intracranial hemorrhage, 8 were controls, and they were really young children between the ages of 0 to 2 years old. They used a linear high-frequency probe and looked through the anterior fontanelle window. They had 2 physicians scanning. The first physician had high sensitivity of 100% and specificity of 100%, whereas the second physician only had 50% sensitivity and 87% specificity with a kappa value of 0.4 only. So they concluded that it can be identified in terms of traumatic intracranial hemorrhage. You can see it when you look through the fontanelle, but it's a very small study, and there's so much variation between the observers that you can't really draw a meaningful conclusion from this study.
Michelle, do you know how long it took them?
Great question. I can't remember off the top of my head, but I have the reference here, so we can look it up after. So this is what they described the findings looked like. This is, at the top would be a transverse view of a normal control, whereas down here is a CT correlating with the finding here, where the brain tissue is pushed down by these hypoechoic pockets of fluid, presumed to be blood. And so they call this acute is a thin arrow, and the chronic is a thick arrow. So it probably takes a lot of practice to get good at this kind of scan, and but maybe has more potential for uptake for our NICU colleagues, for example. But definitely worth a look next time we see a patient that would fit the application. And then another application that we can entertain is, when we suspect an atypical skull lesion, can we take a look and see? I want to guess what this might be. So it's a bit of an atypical lytic skull lesion. It's actually a Langerhans cell histiocytosis.